Okay, so we're going to get started tonight. Good evening. Welcome and thank you for attending our Head of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Michelle Studnicki, and I'm Program Coordinator for the Cancer Institute. There's just a few housekeeping items we want to review before we start. Number one, during the presentation, all participants can type questions into the chat or Q&A section of the Zoom. We will be addressing these questions at the end of the lecture if time permits. Participants are not able to speak during the conference, but again, we encourage the feedback via the chat option. Our topic tonight is Every Picture Tells a Story, Finding Skin Cancer with AI and Breakthrough Imaging. We are incredibly fortunate tonight to have Dr. Howard Edington and Dr. Charles Mount join us. Before they begin, I'd like to take a moment to introduce them and share a glimpse into their distinguished careers. Dr. Howard Edington is a highly experienced surgeon specializing in the treatment of melanoma, as well as cutaneous and soft tissue malignancies with over 30 years in the field. He currently directs AHN's Cutaneous Oncology Program and the AHN Melanoma and Skin Center. Dr. Edington is recognized as a pioneer in the use of oncologic virus therapy to treat non-resectable melanomas. In addition, Dr. Edington's research has been published in numerous peer-reviewed journals. Dr. Edington's education includes an undergraduate degree from Cornell University and a Doctor of Medicine from the Temple University School of Medicine. He completed his residency at the University Health Center of Pittsburgh, UPMC, and his fellowship at the National Cancer Institute, the NIH. Dr. Edington also received an MBA from the University of Pittsburgh Graduate School of Business. Dr. Edington is board certified by the American Board of Plastic Surgery and the American Board of Surgery. In addition, Dr. Edington is a member of numerous professional organizations and societies and frequently invited to lecture at the national and international conferences. Also with us tonight is Dr. Charles Mount. Dr. Charles Edward Mount, MD, FAAD, is a distinguished dermatologist and the co-director of the AHN Cancer Institute's Skin Cancer Center. His clinical expertise encompasses a broad range of dermatological conditions, including the diagnosis and treatment of skin cancer, psoriasis, atopic dermatitis, autoimmune connective tissue diseases, and contact dermatitis. Dr. Mount is known for his comprehensive approach to patient care and his dedication to providing the latest advancements in dermatological medicine. Dr. Mount earned his medical degree from West Virginia School of Medicine in Morgantown, West Virginia. Following his medical school, he completed his residency at the highly regarded Washington University School of Medicine, Barnes-Jewish Hospital Dermatology Division in St. Louis, Missouri. Dr. Mount is certified by the American Board of Dermatology. Dr. Mount is also active as an active member of the American Academy of Dermatology and the Medical Dermatology Society, demonstrating his commitment to professional development and contributing to the field of dermatology. Welcome both Dr. Edington and Dr. Mount. I think we have Dr. Mount is going first or Dr. Edington? I'm sorry.
I think we'll probably... It'll be mostly Dr. Mount because the camera will be discussed by him. I would like to sort of make a shout out to the Pittsburgh Melanoma Foundation during the talk, and we'll hopefully leave all the controls here in my computer alone so I don't sabotage anything.
Okay, but Dr. Mount, it's all you.
All right. Thank you, Michelle, and thanks everybody for joining us this evening. I'm going to go ahead and start with our presentation. So what we'll be discussing tonight and its relevance to AI is where dermatology is headed, where specifically Allegheny Health Network Skin Cancer Center already is, and where we're headed, advancing the standard of care in melanoma and skin cancer management, utilizing devices and technology that are really at the beginning of where, at least in skin cancer management, the use of artificial intelligence is being seen. I have no relevant disclosures on the topic tonight. So here's our team. You've been introduced to Dr. Edington, who it's been a real pleasure. I started at AHN about 10 years ago and have worked with Dr. Edington indirectly for all of those years, and have really appreciated and been grateful of that relationship and his care for all my patients. And I've had the honor to work with him directly here at our Skin Cancer Center at West Penn over the last year and a half. Also with us as part of the team are Dr. Hashim Yunus from Medical Oncology and Dr. Zachary Horn from Radiation Oncology, forming up the tetrad that really tackles skin cancer from an advanced perspective. Top right that's a picture of our vector machine that we're going to talk about tonight, and our cell lab there down at the bottom right. Dr. Edington, did you want to talk about the foundation real quick?
Yes, I want to make a plug for the charity event, if you will, or a fundraising event that is in June 14th. And there's a contact number, that's Beth, who many of you know already. On the left is Jessica Rogowitz, who's a patient of ours, and Lauren Simcoe, who are both tireless supporters, not only of the awareness efforts from the Melanoma Foundation, but also more broadly, the work that they've done to promote AHN and as specifically the Cancer Institute. In the middle, many of you will recognize Bob Pompiani, who also has been a tireless supporter of our efforts. They have generously donated a lot of funds that go directly to research. They're not bricks and mortar donations at all. And if you have a chance, please join us on the 14th. It's a great celebration for the survivors and recognizing those folks that we need to cure. Thank you. And I'm going to back out and leave it to Eddie at this point, Dr. Mount. And I couldn't say enough good things about Dr. Mount also. We are absolutely delighted and honored to have him.
Thank you, Dr. Edington. So why is this important? Why have a dedicated talk of skin cancer and AI? Well, lots of reasons, and I'm sure many of you on the meeting tonight have been personally affected by skin cancer or potential skin cancer concerns. And if you haven't, I'm sure you have had a friend or a family member. And why is that? Because that's the most common cancer in the US and worldwide. By the time Americans reach the age of 70, 1 in 5 of us are going to have skin cancer. And that's pretty astounding to think about. If you're sitting in a room right now with coworkers, friends, or family, and there's 5 of you in the room, like by the time you're all 70, 1 of you is going to experience some kind of skin cancer. And more than 2 people die of skin cancer in the US every hour. I'm a child of the 80s and the 90s, and I definitely had my share of sunburns at the beach, and sunscreen was like, we'll put some on after the fact kind of a thing. And knowing statistics and what we've researched in melanoma and skin cancer, if you've had 5 or more sunburns in a lifetime, that doubles your risk for melanoma. And I'm sure I've had twice that, before I was probably 12. But as scary as that is to hear about, the risks and the frequency of skin cancer, when you detect it early, the survival rate is amazing. And this is a cancer that you don't need a scope or a $2 million machine to look into the body to find, or some invasive surgery to find, some uncomfortable thing. You need a skin check and potentially some of this advanced technology that we're going to cover tonight. So again, as we talked about, it's one of the more common. It is the most common type of skin cancer, but melanoma, this graph on the left is specifically breaking down melanoma and where its place is amongst the other major types of skin cancer. And that rate, unfortunately, it is climbing as well significantly. You can see that graph on your right from 1975 to 2020, just that rate taking off. And there's various reasons for that. A lot of that is increased sun and sun-seeking behavior that started in the early part of the 20th century when tanning and the look of having color became very in vogue versus before that, being pale was seen as more of an elite status symbol. But in the 20th century, having color of your skin really became the look that everybody strove for. So they sought tanning beds, they sought outdoor sun exposure, and you really saw as the population aged from that exposure, skin cancer began to take off. Interestingly enough, mortality has not followed that same graph, and there's a whole nother talk on explanations about that, but part of that is the excellent care of skin cancer and early detection. So it's a very expensive thing to take care of cancer, including skin cancer, as you might imagine. The annual estimated cost in the US is over $8 billion with a B, and just for non-melanoma alone, it's close to $5 billion and just over 3 for melanoma. Melanoma can be a much more expensive disease to treat because it is, more rapidly metastatic and life-threatening, but non-melanoma skin cancer just vastly outnumbers melanoma. So that's why the cost of treating that overtakes melanoma. So across all stages of melanoma, the average 5-year survival rate in the US is something like 94%. Whereas if it's detected early, we're talking stage 0, stage 1, it's going to be more closer to over 99%. But once it gets to the lymph nodes, and we would categorize that as stage 3, that survival rate dips down to 74%. So you can see that dramatic, that precipitous change once it gets away from the skin, where essentially if you caught it early in this confined to the skin, that person almost doesn't need to worry about that skin cancer coming back or spreading. But once it gets a little bit further into the lymph nodes, it becomes a much more dangerous thing to be dealing with. And once it spreads beyond that to distant organs, stage 4 type disease, it really gets to be a nasty, aggressive thing with a lower survival. That is changing with the advent of immunotherapy and targeted therapies, but still a very much more serious thing to be dealing with as a patient. So importance of prompt diagnosis and prompt treatment. So stage 1 patients, if they're treated, that being surgery and excision, 30 to 59 days after a biopsy have a 5% higher risk of dying from their disease at the same stage compared to somebody that's treated within 30 days. So the effort is always having the melanoma definitively treated, definitively excised within 30 days or about 4 weeks of when the diagnosis was made via biopsy. And you can see if it stretches out to 119 days, about 4 months out, they have a 41% higher risk of dying, again, from the same stage of melanoma disease versus if you get it out earlier. So I go over these stats just to illustrate with the importance of, not only excellent training and excellent providers, but moving, the bar forward in terms of technology that can really assist us in this endeavor. So, I don't know how many medical providers we have on the call tonight. Maybe some of you are, looking down at your skin right now and saying, "Oh my gosh, this is me." But there's a lot happening here. These are a lot of what we call melanocytic nevi, or what the lay term is moles. These are benign clusters or benign tumors of pigment-producing cells called melanocytes. And the important thing is, a lot of us as humans growing up looking at our skin every day are often concentrating or fixating on these moles that we've had for so many years. Like, oh my gosh, this one looks funny. This one's changing. Is this a melanoma that I've had since I was 5 and now it looks funny when I'm 40 years old or so? But it's important to know that only 20 to 30% of melanomas are going to be occurring or found in a previously existing benign mole. Much more of them, 70, 80% of them, arise on normal appearing skin that had nothing there. But then once that lesion popped up, it was a melanoma from the start. So that's one of the reasons why when we're doing skin checks and using technology, identifying new lesions is of importance. And having just the sheer fact of you put everything else aside, sunburns, tanning bed, family history, genetics, immune suppression, just having 50 or especially more than 100 melanocytic nevi on a person's body by itself is a statistical risk factor for that individual of having melanoma in their lifetime. And when you have an exam like that, I mean, that even gives a little bit of, pause or anxiety to somebody that's well trained in examining moles and skin cancer. So when you have a patient that has a lot of spots, like where do you start? And it really can be a daunting task. And what we've lived by in skin cancer management for a long time, it's when in doubt, cut it out. And that, that hasn't completely gone away, but we're looking for technology and approaches to not always live and die by that way of managing things for our patients' benefit. So how do we move forward? There's different ways, and a lot of this talk is going to focus on Vectra, which we utilize here, but I'll cover a couple of other technologies quickly. So non-invasive testing, this is something called DermaSensor. This is an FDA cleared, not FDA approved. There's differences in those certifications from the FDA. It's not as stringent in terms of studies and data that's required to be FDA cleared. But this little handheld device basically uses very fancy visible light to look at skin lesions to be able to identify, is this a potential skin cancer or not? And it has been tested to identify melanoma and non-melanoma skin cancers. It has what's called high negative predictive value and high sensitivity, whereas it does have a low positive predictive value and specificity. So this is a good thing that, can help find potentially some melanomas, but it's also going to identify a lot of benign lesions. So if it does identify something of concern, it definitely still needs a biopsy and or evaluation by a dermatologist. This is not something that I think you'll see in dermatology offices or skin cancer center offices. What this thing generally can do, and you have to pay a subscription service to use it from the company, a trained dermatology provider, can do the same thing by looking at it in a few seconds and maybe using this thing that we always carry around, dermatoscope. It may be used in more primary care settings or where there's not as much access to dermatology services. There is this tape testing. This is not strictly AI, but this is, it just kind of falls under the umbrella of where we're going in dermatology and skin cancer management and detection. There's a few different companies out there, but there's one main one that offers this tape test that basically you apply this sticker onto a concerning lesion. You have to put 3 different pieces of medical tape essentially, and it painlessly peels off some of the cells from the mole to collect some of the DNA, and you send that off on basically what looks like a cardboard voter registration card to their lab, and they're able to look for DNA that can be potentially associated with mutations in a melanoma. Again, this is good. This is a good test for ruling out a melanoma at that point in time. It doesn't rule out something becoming a melanoma, 2 weeks from that point of the test. But if it does come back as a negative test, you can feel pretty reassured that it's not a melanoma at that day and time that you did the test. But if it's positive, it needs an evaluation formally and a skin biopsy for pathology. There are some limitations there on the left. It has to be a certain size. It's not approved for pediatric cases. You're not supposed to use it on genital skin, the palms and the soles. And that's just a couple of genes that test is looking at. So let's get into more AI type technology. So this is our baby. This is Vectra. This is specifically the Vectra, what's called WV360 or whole body 360 degrees imaging system. Canfield is the company that produces this. They have lots of different camera systems. They have a 180 system where, if you look in your top right picture there, it's essentially half the machine that we have, and the patient has to flip around to get the other side of their body imaged. This machine is operated by one of our staff members, Emily, who's been doing this since we got the machine installed, and she does an excellent job walking patients through the experience. And essentially, it's like coming in for your skin check with your dermatologist, except you're inside that machine, like you're at the airport security screener. This is not using any kind of ionizing radiation. This is all visible light. These are cameras, 46 cameras to be exact. There's 46 camera pods. There's 2 cameras per pod. So it's what we call stereoptic vision. It's like having both your eyeballs looking at something. So we need two eyeballs to give us stereopsis, to give us depth perception, right? Well, each one of these pods is giving us stereopsis from that vantage point, looking down at the person, the patient in the middle, with cross-polarized light coming out of the bulbs, and then it's being polarized one direction when it comes out of those flash bulbs, and when it goes back through the cameras, it gets cross-polarized, and that's exactly what happens in these dermatoscopes. And how I convey that to patients, why that's a good or helpful thing scientifically. If you ever wear a pair of sunglasses that are polarized versus non-polarized, you'll notice if you wear polarized sunglasses and you look at in a pond, it takes the glare off, it takes off certain distractions, and you can see maybe a foot into the water, you can see the rocks, the fish, etc. You can see down in there what's underneath. It gets rid of that light scatter that's reflecting off the water. And when we use these scopes, and then that's what this machine is doing, it's allowing a more accurate representation and visualization of pigment and other structures just barely underneath the skin surface. And we can use that to assess if something has a benign or potentially malignant pattern. Okay. So that's why polarization is important. So 46 cross-polarized stereoptic camera pods, essentially. And since we have the 360 system, it's able to create a three-dimensional avatar, or essentially a cartoon image of the patient. As you can see there, the individual stands undressed. The more you're undressed, obviously, the more it can detect. What I tell patients is, I'm pretty good at diagnosing what I can see, but if I can't see it, I'm not too helpful. So this after this gets your 3D image, it generates it into that, and then it will auto detect certain lesions that might be of concern. If it's the patient's first Vectra imaging visit, it's going to create their images. It's going to assess them and see what might be a concern from a distance from those pods, and that will allow the person, our staff member running the machine, to then home in with the handheld device that you can see on your lower left screen. And that is essentially, there's a handheld dermatoscope that you can then hold up to individual lesions and tag what it will see where it is. So like over the person's shoulder blade, over their left shoulder, on their hip, their cheek. And we will be able to track that and monitor that for years to come. But they have this software in this AI system, essentially, that has been taught from, this is what a melanoma looks like, this is what a benign mole looks like, and it's going to assess and look for melanoma and other concerning things that could be skin cancer. Okay, so that's pretty cool. So assessing the entire body, in that process for creating that image, that first 3D big avatar image takes about 30 seconds. It takes however many minutes longer after that, anywhere from 5 to 20 minutes more, to individually hold up their dermatoscope to concerning lesions one at a time, depending on how many spots there are to look at. But the whole process could be 15 to 30 minutes. But yeah, the big machine operates in about 30 seconds. So there's that handheld device. The patient's avatar can be spun around. We can zoom in on individual lesions. And as the patient is getting this done year to year, their 2024 image is going to be overlaid on their 2025 image. So the machine is going to know that mole was there or was not there last year. That mole has grown 2 millimeters. That mole's pigment pattern was this way last year. Now it's a little bit that way this year. So that really helps me, or whoever the dermatology provider is doing the skin checks, to hone in on what really needs my attention, and to feel reassured if I see something on exam that I'm not worried about. Oh, that was there, that's not changing. So the point being to increase skin cancer detection, but allow me to feel reassured that we can continue to observe other benign moles or lesions. And you can see that side-by-side comparison that you can do from the first visit to the next. Dermographics is their software system. That's the dashboard there on your upper right. And as you do this visit for patients, it's going to tag these in a lot of different fancy ways, so we can really keep an eye on things. The way this has been done previously for decades is in Pittsburgh, there was one main professional photographer, and I don't know if he's on our call or if he's still taking photos, but he did some amazing work where patients would have to go into his studio and basically take a million different medical poses, so he could take very accurate medical photography shots, and you would get that on a DVD, or a lot of patients had literally an entire photo album that they would bring to their dermatology visits, and they would hand you, and you would flip through their old photos, or sometimes we could load their CDs and try to look and compare old photos to the current exam. And I used to do this in our Epic system where, in our work phone, I could snap photos and upload them into the electronic health record. But the pitfall there, number one, the camera not nearly as good, right? Two, there's still a subjective human that is looking at an old picture and a current body and making a human decision of, I think that was there. I think it looks the same, versus the software system being objective, saying it was there. It was measured to this. This is what the pattern was like. So it takes out that potential human error of, comparing photographs and looking at it year to year. And again, we can see how we can track individual lesions like this. That bottom picture, that's showing the change that might be seen over a 2.5 year follow-up. So, if we saw a patient that mole had changed in that way, that would warrant a biopsy. Even if I, did the skin check first and looked at it and wasn't that concerned when I first looked at it, but if the Vectra had identified to me, hey, that thing has grown, that's going to probably change my decision making and say, okay, we need to biopsy that. Most of us are probably done making moles around 40 or 45. So if I have a 55, 65-year-old patient and they have a pretty benign looking mole that showed up that's new, that we either know is new, just me and the patient know, or this machine has identified as new, even though it looks pretty benign on exam, again, that's a factor because most melanomas come from de novo new lesions. I have to really have a good reason in my head to say, okay, we're not going to biopsy this, because otherwise, if I don't have a good reason, I'm probably going to have to biopsy it. So what's the benefit here? Earlier detection, as we talked about before, equals improved survival. Earlier detection leads to reduced costs associated with treating more advanced disease. Also, if we're noting with this kind of technology that we don't see any concerning features, there's no changing concerning moles, I tell patients this technology is going to do two potential things for you. Most importantly, earlier detection of a melanoma if it occurs. Secondly, and patients have been through this for years. They get 1, 2, 3 biopsies every time they go see their dermatologist. This is going to decrease how many unnecessary biopsies showing a benign or slightly atypical, mildly dysplastic, moderately dysplastic mole. How many of those biopsies that patient has to endure in the rest of their life. And through all this, our aim is to increase patient satisfaction and confidence in healthcare and the services that we provide specifically here at AHN for skin cancer management. So, this is the beginnings of this. So this is just the beginnings of advancing the state of our medicine so that maybe someday, hopefully someday, I'm sure someday, years from now, that non-invasive modalities and tests might completely replace invasive biopsies and testing. So, this is where we're headed. We're just at the start of that. So why is this a big deal? This is a provider down in the Miami Cancer Institute. You can see her opinion on there. And she more or less has the same sentiment that I share. So this is an example. This young lady had a pretty overall normal skin exam. And that lesion, if you look on her right, your left, that little pinkish brown area I can tell you on a skin exam, that's not the first thing I look at and say, oh my gosh, after, doing dermatology for over a decade, like, oh, I think that's going to be a melanoma. That little brown freckle in the middle there. I mean, but I can tell you that ended up being a stage 0 melanoma in situ. Same thing with this little freckle here down on the earlobe there at the beginning of where the cartilage starts. You can see there's other similar freckles or what we call lentigines elsewhere on this individual, but Vectra identified these two different lesions on these two different patients, and we have other examples. These are just two provided, but these are things that if you just without Vectra, if you biopsy this lesion and pick things that look similar on the patient's body, I mean, you're going to be biopsying 20, 30, 40 things. So that's where something besides just even a human trained eye, this technology earns its place, I think. So we have a little news clip here that was featured a while ago, but I think hits home. It was one of our patients that Dr. Edington is taking care of, and I'll share that with you now.
Their toolbox, artificial intelligence, helping doctors focus on spending time with patients. And as Channel 11's Alyssa Raymond found out, it's already proven to be life-saving.
This machine uses artificial intelligence to diagnose skin cancer. It has 92 cameras. We spoke with one patient who was skeptical about AI at first, but now she's grateful.
Do you think this saved your life?
Oh, for sure.
Katrina Barger started going to a dermatologist in middle school.
I'm fair-skinned with a lot of moles.
At 26, she noticed a spot on her knee, which turned out to be melanoma. Because of her history, she sees a dermatologist every 3 months. But back in the fall, Katrina was the first person to use this whole-body imaging system at West Penn Hospital. It's one of only 15 devices in the country.
The Vectra found that I have 745 moles on my body, so it can be hard for any human to keep track of that, me or my doctors.
The device also found a cancerous spot that wasn't on Katrina's nor her doctor's radar.
It's hard to say how long that one would have gone undetected if the Vectra hadn't found it.
AHN says it's been using artificial intelligence for more than 5 years in the world of radiology and imaging, predicting sepsis. And they're even testing out a system that could alert hospital staff.
All right. The rest of that interview doesn't pertain as much to our skin cancer talk today, but just kind of goes more into AI in general in our healthcare network. So yeah, that was a personal patient of ours that day one, the machine being here, you can see just made a difference in catching something early. Again, I believe with her melanoma, correct me if I'm wrong, Dr. Eden, I believe hers was also stage 0 melanoma in situ. Again, melanoma in situ. Stage 0, it's in the top layer of your skin, your epidermis. I always say that's like it's stuck in the icing of the cake. Once it gets into the cake, then the disease gets more aggressive and the recurrence rate starts to climb depending on how deep it gets in the cake. But that's where you see it being a 1 or less than 1% chance of it ever recurring in that stage 0. So that's 3 patients where it's been caught as early as possible.
Yes, both of those patients you described are stage 0, where the survival should be close to 100%.
So, why is this special for us at AHN to have this technology? Well, this is a map of the U.S. and the Eastern Seaboard of locations where Canfield Vectra 360s are installed. You can see we're the only one there in the Appalachian Mid-Atlantic area. There's not one in Cleveland. We have the only one in Western PA. There's not one in West Virginia, not one in Cincinnati. There's up in Buffalo, or I think actually Rochester is one. And then the other one is at Penn over in Philadelphia. There's only 20 of these in the US. So, and a lot of them are in New York City, DC, DMV area, or Boston. And we can get into some of the background if we have time or if that comes up, but 20 in the US. And so I think I feel blessed to be at one of these sites where this was made a priority and the uniqueness of this technology was embraced from almost, I would say, day one, that we even brought it up as, hey, this is something we should look into, we should consider. And the way it's changed my practice, I mean, I could probably go on for another hour talk about, some things it's helped me and feel more confident in. But you can see the difference in Australia and Europe, how it's kind of more widely utilized across those geographic areas. This Australia's map doesn't even do it justice, because in each one of these little pockets, there's like 6 machines, and they actually have the largest melanoma cohort study going on in Australia right now, between their major academic centers in Brisbane, Sydney, and Melbourne. You can see the King of England there came over to visit and talk with their head researchers. And I've been in communication with those researchers in Australia, and I'm hoping to see what I can learn from them and eventually take a trip over to Australia to their sites and spend a few days with them, just to kind of see how they are utilizing this technology and bring that back, because they've been really more aggressive and using it for a longer period than places in the United States thus far. So in summary, again, thanks for listening to me talk about this. Skin cancer is very common. It's the most common cancer in humans. And unfortunately, at this point in time, and for the foreseeable couple of decades at least, it's continuing to increase in incidence. And I can't stress it enough. Early accurate detection is essential to reduce mortality, that is to improve survival, to reduce morbidity, the severity and the complexity of the treatments that are needed, and as a system that we all contribute to reduce the costs of just managing these skin cancers. And this technology that we went over tonight is really it's not the end all be all, but it's such I think a big thing in an advancement in terms of trying to do something different than what's been done historically, and how to increase our survival of our patients, while also reducing the costs and the invasiveness of our testing. So again, thank you for all your time and attention tonight, and I'll turn it over to our coordinators running the program.
Thank you so much, Dr. Mount. Very, very interesting. We have some questions. So are you and Dr. Edington ready to answer some questions?
Sure.
Okay, first question is, do the 5 sunburns that increase the risk of melanoma need to be blistering sunburns, or is it any sunburn?
There's correct me if I'm wrong on this, Dr. Edington. There's harder data specifically on blistering.
Yes, that's my understanding too. The whole pathogenesis remains incompletely understood. I think the damage that occurs may be partly the skin having difficulty repairing itself, which I think is consistent with the pathogenesis of this disease.
Okay, thank you. I think we went over this. How much does the screening with the Vectra 3D machine cost?
$250 each time. It's not covered by any insurance plan or carrier, any insurance payer company in the U.S. thus far that we're aware of. But yeah, our institution charges $250 flat rate per patient each time you do it.
Now, Dr. Mount, is that to change? Or are we working with insurance companies to try to get that to change? Do you think that's a realistic expectation?
I don't see it happening probably this year. We've had meetings with different payers on that, and provided reasoning why it should be considered for them to add on their formularies as a covered procedure or benefit. It hasn't been approved by any insurance carrier thus far yet, though.
So
I
more to
think it's
come.
important. Oh, I was just going to add, Edington, that the price that's charged here is significantly less than elsewhere. So we're delighted about that.
We're about half.
Yeah, a half, I would say. And I think that the carriers will eventually support the technology simply based on review of the numbers, if indeed less biopsies are done, and if indeed it shifts the incident rate, if you will, to the more benign or favorable outcomes. It's just a no-brainer that if this works as a screening device to save money as well as lives, it'll be supported.
Great. Let's see, next question. If you have basal cell, are you prone to melanoma?
Specifically, there's not a direct link of basal cell to melanoma, not a significant higher risk. I mean, I would tell, I mean, the patients are in higher risk in general of skin cancer, so they need follow-up, but not specifically to my knowledge.
Okay. Well, here's a good one. Vectra would not be able to see a mole on the soles of the feet, question mark. That is where my pre-melanoma was located. It was a mole I had my entire life. So I think the question is, can the Vectra see the soles of your feet?
Not unless you sit in a chair and point your feet at the cameras, unfortunately. There's 3 places it can't see. Hair-covered scalp, the area of tissue in the groin, we'd call that the perineum, between the buttocks and the genital area, the soles of the feet, basically any skin that's covered with hair, clothing, or skin folded on skin, it can't see those areas, unfortunately. It's a camera.
Okay, let's see here. Next question. How does the Vectra scan those individuals with multiple tattoos? Oh, another good question.
How does it scan them?
I guess if it had, I think the question is, if you have tattoos, does that influence the Vectra?
So it depends. So a couple things. If the person is getting new tattoos year to year, that might throw off the software. What the camera's looking for change. So if they're adding tattoos, if they're changing or adding color, that might throw off, a little bit of the software. The answer is it will still look through tattoos. Okay, that's answer number 1. I should have started with that. But there's factors that have to be considered. If you're getting ink layered, if you're getting colors changed, if you're adding artwork on, you're gonna have to the operator, the person running the machine, and the provider reviewing the images are probably gonna have to look at it a little bit more closely, but it can still definitely be done. It should be noted that tattoos can throw off a human dermatology provider looking for skin cancer too, though. So that's why dermatologists generally recommend don't tattoo over a mole, especially with dark ink.
Okay. This next one is not a question, but thank you so much for supporting the Pittsburgh Melanoma Foundation and helping us raise awareness. You've saved my life. You've saved my life 3 times. And that's from Jessica. The next question is, how do I schedule an evaluation at West Penn Hospital? How full is the schedule? I can speak to that. If you would like to schedule an evaluation or have any questions, you can call our Hope line. It's 412-578-HOPE or 412-578-4673. And I believe, do you know how, Dr. Edington or Dr. Mount, how far you are, your team scheduling out? I don't think it's very far. Maybe
No, it's about 3 or 4 weeks, and we
Okay.
can certainly adjust the schedule as needed. And I think we've done well. It's funny, I got a comment from probably another city where they were told they couldn't be seen till 2030, which is
Oh.
incredible.
Wow.
So we're ahead. We are very cognizant of the anxiety that a wait can cause, and so we do everything we can to get folks in.
And I will repeat that number again at the end for anybody who might have missed it. But the Hope team or Hope scheduling line will take good care of you. This one is so another question about how you get an appointment. And when should someone have this done? I don't know if this is a question on yearly or if you have concerns.
When they should get it done?
Yeah, the question is, how do I get an appointment? We answered that. When should someone have this done?
Any patient is open and welcome to it, and that's how we've kind of envisioned this. So any patient can self-refer in, number one. If you have an outside dermatologist wherever you are, this is open to you. Your dermatologist can refer you. If your dermatologist doesn't bring it up or says you don't need it, but you still want it, it's still open to you. You call the appointment line and we will perform the test and give you the images, and you can take the images back to your primary dermatologist. We had really built it, to be as a service to enhance our care, but also just to be a device and a technology that could really expand and improve the care of skin cancer screening across the entire region. So if you want it, call the number, schedule it, come and get it. If you don't have a dermatologist, if you want us to be your dermatologist, we'll also do your skin exam in conjunction. Sometimes the same day, but a lot of times a different day, you'll get your skin check and we'll review the images and go over them. But in terms of, when do you get it, who needs it? If you're thinking you need a skin, the best and easiest answer is, we've gone over this over the years of like, do I need a skin exam with a dermatologist? And if you're thinking you need a skin check, you probably do. So get your skin checked in person with a medical provider, a dermatology provider, skin cancer expert, and get the vector imaging. Now, in terms of frequency, most patients that are going to get this are going to get it done probably at least once a year, so you can look for change over time. There are some patients that are low risk that elect to do it every 2 years. And then we have a handful of patients that Dr. Edington and I take care of that have, had multiple melanomas. They have a lot of moles. They get it done every 6 months in conjunction with frequent skin checks with their provider.
I think there's a follow-up. I'm thinking this one is, can anyone come in for a vector scan? I think the question might be, what is the age? Is it 18 and over, 16 and over? Does it go up to 99?
Yeah, there is no upper limit, but we would say adult patients, 18 and older.
18 and over, okay. The next question,
to touch on that, pediatric melanoma is a very different thing than adult melanoma. It generally does come from pre-existing congenital melanocytic lesions or this other category of things called Spitz nevi. So it's just different than adult acquired melanoma. That's one of the reasons why we wouldn't want to. We're just not going to be doing that on probably juveniles or pediatric patients.
Okay, so 18 to 99 then, right?
Mm.
How accurate is the Vectra and its AI technology on the first scan as opposed to the second comparative scan?
I'd probably have to have Canfield folks or some of the folks involved in more of the studies in Australia to give you numbers on that. It depends on what you're calling accuracy, I guess.
That's a great question, though, and I think as time goes by, we're going to find that there's unequivocally an increased advantage to getting repeat scans.
Mm-hmm. Yeah, I think I'm almost more excited for most of my patients, their second exam, their second vector than their first, because I want to see that serial change over time, as Dr. Edington's, I think, saying.
Okay. A lot has been presented concerning melanoma. Can the Vectra detect and track basal and or squamous cell carcinomas?
Yes.
Okay. Next question. My son has over 50 nevi moles. How soon can he get an appointment for this procedure? I'll take that one. Once again, you would want to call our Hope line at 412-578-4673 or 412-578-HOPE. They should get you in within the next 3 to 4 weeks.
Yeah. If by son we're saying adult, because we're not.
Oh yeah, I'm sorry. Yeah, if your son is over 18.
Yeah.
I'm 70 plus, and a while ago, the dermatologist who my PCP referred me to did some tests on several moles and said it was inconclusive. Should I sign up for this test?
Yes.
Okay. Here's a good. I think that
The other thing is on that note, a biopsy, a mole biopsy that is inconclusive, that's like red flags to me. So get Vectra and get those pathology results reviewed by a dermatologist, because those biopsies showed something. It might need, somebody to read through it that understands the pathology report to explain to you what it showed, but I don't think that all those mole biopsies were truly, quote, inconclusive. So you need the pathology reviewed with your dermatology provider and get your Vectra to help enhance your care.
Okay. Next question. Does the amount of body hair on the chest and back affect the scan?
Yeah, we didn't cover that. That goes along with the lines with what it can't see. So if you do have significant amount of body hair, we generally recommend clippering it down with a clipper guard, not shaving with a straight blade or a razor blade to the skin. We recommend clippering it maybe a few days before. And the reason we recommend doing it a few days before and not shaving with a blade is because if you get shaving irritation and you get these red bumps, those are going to be things that the machine might pick up on a little bit. Not that we can't, if that happens, we can look at the results and be like, that's shaving irritation. That's, whatever it is. It's just gonna add a little bit of an extra step into the whole process for your review of your images.
Okay. Next question. Is this presentation available to view later? And how do I receive a link? Very good question. Yes, this is being fully recorded tonight, and this, as well as all of our past lectures, will be posted under the Head of Cancer playlist. So we'll give it about a week or two for this to get uploaded, and it will be available to rewatch, or if somebody hasn't seen it for the first time, it will be available on YouTube. But we will send, actually, if you're signed up, anybody who is signed in today to the Zoom will receive an email stating that it has been uploaded. So, can you use a flexible spending account to cover the cost of the Vectra scan? I don't know if Dr. Edington or Dr. Mount, if you know that, but I'm sure if you call the 412-578-HOPE or 4673, they would be able to answer that question.
Yeah. The answer is yes.
Okay. Perfect. And then the last question we have for tonight: should a person have both a visual body skin exam and a Vectra?
Yeah. In a place like Pittsburgh, where we have a lot of access to dermatology exams, yeah, one doesn't replace the other at this point in time. The two together fill the weaknesses of the other in more appropriately.
Okay.
If this machine was in the middle of Alaska or Montana, where the closest dermatology skin cancer clinic was 6 hours away or plane ride away, this machine could throughput and screen a lot of people without a formal dermatology skin cancer exam. But when you have them both available to you readily, it creates a much higher quality service for you.
And I'm
Good.
just going to answer I'm just going to read the last question, and I think we're going to wrap up on questions and do our closing remarks. Can I get a physician appointment first, and then can he or she decide what tests are needed?
Yes.
Okay. So, very good questions tonight. We're going to close now. If we have no additional questions or comments. We'd like to thank everybody for attending our Head of Cancer lecture series this evening. As a reminder, tonight's lecture was recorded, and if you're interested in rewatching tonight's lecture, check back on the AHN YouTube channel, www.youtube.com, for the full recording in about a week. And this also includes our past lectures, as stated before. And if you would like to schedule an appointment for Dr. Mounts or to have the Vectra scan, you would want to call or Dr. Edington, you'd want to call our Hope line at 412-578-4673 or 412-578-HOPE, H-O-P-E. And they can get you all scheduled and answer any questions you may have. Thank you for a great presentation tonight, and thanks to all who attended this lecture, and have a nice evening.